Hello, everyone. This is Shelley from CVI 2025. I'm really privileged to be with Dr. Shelley Hall again for the second year. And thanks for putting this session, or at least track together, which is Advanced Heart Failure and CVI. Dr. Hall, thanks for being with us.
Thanks for having me.
Right. One of the sessions during this conference is the focus on that overlap with interventional is the monitoring as well as therapeutic devices for patient with advanced heart failure. So let's dive in.
Yeah, I mean, this is such a fun space nowadays. And I'm kind of the old school, I do both, which doesn't really exist nowadays. So I do what two people do now, which is entertaining to me. But the reality is that devices are now a real part of management and for the heart failure patient, both from a monitoring perspective and from a therapeutic perspective. And while there's some that are currently available and utilized, they're still markedly underutilized. And then the amount of trials in research is really exciting.
Yeah. So let's start with the monitoring.
Okay.
Yeah. What do you have now? Like, if we count the two or three most principal or important devices used for monitoring of heart failure patients?
Yeah, I mean the one that's commercially available is called CardioMEMS, and it's been available for a long time. But like every new intervention, if it's expensive, it is hard to get to your patients, and it's taken a really long time to get a national coverage for the device. It's finally happened, but when it's been out at least over 7 years and only now starting to gain traction, you end up with competitors getting into the space before they've had the benefit of sort of owning the field. This family of devices, we call them PA sensors, are implanted in a pulmonary artery, and they essentially transmit the pulmonary artery readings. And so if you track that, you can see when they start to have elevation of the pulmonary artery diastolic pressure and signs of congestion, to then treat with diuretics before they develop the clinical symptoms. The next device that's coming in that's been joining the team is the Cordella, which is a very similar device, put in very similarly and does the same thing. And so ultimately, again, competition is good. It drives price down and it pushes innovation. And now we've got these two in the space to potentially do that.
Yeah, and CardioMEM has been there for a while, as you said, 6 years,
Yeah.
and requires some kind of system-based where the patient can be monitored, like an ICD or a pacemaker.
Correct.
Or
I think
something.
one of the tragedies of monitoring devices is they're not monitored.
Yeah.
I mean, this was a
It's bad.
failure of many of our pacemakers or defibrillators, is they had monitoring technology as part of it, but nobody monitored anything.
Right.
And so, yes, there's a patient component. The patient has to lie on the pillow or whatever contraption may be associated with a monitoring device and transmit the information on some kind of regular basis. Then on the provider side, you need some kind of organized methodology where somebody is looking at that information on a regular basis, because it's all about trends. It's not a single reading. It's what's happening. Are those pressures rising? A little blip that goes back down, heck, that's called pizza, right? But the reality is to catch that rise and intervene for the benefit of the patient. And so you have to have patients who will comply, and then you have to have a system in place to monitor.
Let's move to therapeutic therapies right now, transcatheter or interventional therapies.
Oh, Lord, there are so many. There are so many. There are ones that are trying to produce diuresis or reduce congestion. And they'll be on the venous side, such as the Daria device, which essentially decreases venous return to the heart to try and allow the renal vein to decongest and the RV to decongest, so that can improve function and promote diuresis. There is, on the arterial side, there are things like the second assist, and I'm blanking on all the names, but they're to try and increase forward cardiac output. There's so many, and they each have their pros and cons, and there was a discussion about, do you try and be in all the trials or do you pick one? And I think it depends upon the institution. What is your volume? What is your capacity? Because if you enroll in too many trials and then you don't really enroll patients, then you're not doing the research a service. Then there are things looking at neurohormonal modulation, both on the already approved side and on the research side. So the two families of interventions that are currently approved is baroreceptor activation therapy, what currently known as the barostim, and the cardiac contractility modulation, or the CCM. Both have been approved, but again, slow adoption into the community. Where is the patient niche? Getting payers, again, to pay for that is a challenge. And so it's being slowly adopted, never as fast as we would like in our community. And then behind that is a whole family of other neuromodulators in research.
But I feel like has to be coming from a center where heart failure is really robust to drive that need for the interventions to jump in. It's like as like a structural heart team or like a heart failure team, where you have the devices, the person who is referring, and see the indication for it, and then the implanter.
Yeah, absolutely. And it starts even before that. Most stage C heart failure is with general cardiology and with primary care, not with an advanced heart failure doctor. So we have got to get to those patients, because that's where they benefit. When they get to us, it's too late for those, and then we're looking at transplant and LVAD.
Right.
And the reality is we already say they're referred too late for transplant and LVAD. So we've got to get the general community to understand the importance of these devices to potentially delay the need for advanced therapies. Now, that's always been a challenge. They didn't mind sending a patient for a defibrillator because the patient was going to come back to them no matter what. Their perception when they send to a heart failure doctor is they lose the patient to the heart failure doctor.
Exactly.
So we have to break that reputation.
Yeah.
We have to collaborate with our proceduralists, and because they're happy to do the procedure and not care for the patient. And the heart failure people are known to do all of the trudging care afterwards.
Yeah.
But the reality is we've got to work with our general cardiologists and our primary care to say, we can work with you as a team, or I think we'll eventually be able to help their offices develop the infrastructure to monitor these, what I call these intermediate devices for heart failure. So they don't need us, but we're aware, and then there's a relationship that's developed. So when they are deteriorating, they've already had that intervention. Now's time for the advanced heart failure to start looking at those final options.
Absolutely. Well, Dr. Hall, thank you so much for enlightening us about how to patient selection, as well as the monitoring and therapeutic option for patients using transcatheter therapies.
Absolutely. Happy to do it.
Thank you. Watch these videos and others on CVI YouTube channel. This is Shelley coming to you from Austin from CVI 2025. Thanks again.